it.
Yep, there you go. You're
Check,
fine.
2.
Yep.
Good evening, everyone. You're very welcome to this evening's meeting. Fiona McGee is my name. I'm a GP locally. So delighted to welcome everyone, and also everyone who's joining us around the country on the webinar. So I'd like to introduce our first speaker of the evening. Dr. Nicola Ambrose is a recently appointed consultant rheumatologist at Blackrock Clinic. She's a graduate of Trinity College and trained initially in Ireland. She was subsequently awarded a fellowship by Arthritis Research UK. She travelled to Imperial College London and completed her PhD in Behçet's disease. She has an area of special interest, particularly in rheumatology of adolescents and young adults. She obviously has an interest in Behçet's disease as well, and all areas of rheumatology. So I'd like to welcome Dr. Ambrose to speak. Thank you. And just to mention at the end, when we're asking questions, could I ask anyone with a question to wait till the mic arrives with you so that everyone can hear. Thank you.
Thank you. Thank you. So I am going to talk a little bit about juvenile idiopathic arthritis tonight. And just, I guess my take-home message is these are a different cohort of patients to the adult rheumatoid arthritis patients that you're more used to seeing. So yeah, I think that has already been covered, so I'll carry on from it. I've been at Blackrock since the middle of last year now. What I'm going to talk about this evening is juvenile idiopathic arthritis, what it is. I'm going to talk a little bit about adolescence in general and other complexities. I'm going to talk a little bit about the situation in Ireland regarding JIA treatment at the moment, and I'm going to talk a little bit about an adolescent and young adult service to provide age-appropriate care to patients. So, what is juvenile idiopathic arthritis? It is not very early onset rheumatoid arthritis. It's an entirely different thing. JIA is actually a very heterogeneous group of conditions rather than just one condition. It essentially encompasses all childhood arthritis of unknown cause occurring before a patient turns 16. That persists for more than 6 weeks. There are many different subtypes, and typically people think of toddlers who maybe have a giant knee, which is the oligoarthritis. This is something that usually it's thought that people grow out of it, and it used to be the adage that someone with JIA would grow out of it and it would not still be present in adulthood. And really when people talk about that, they were talking about this oligoarthritis of maybe a toddler with a big knee who had been walking, who stops walking and therefore comes to attention. But in fact that's only about probably less than 50% of all the JIA cohorts. This type of arthritis is associated with an ANA positive rather than a rheumatoid factor positive. And those with a positive ANA are quite likely to get uveitis, which can be sight-threatening. There are lots of other different types. And the other types tend to come on a little bit older. And again, I'm going to talk a little bit in depth in future slides, but just to mention there are several different types, and they are quite distinct from the adult type of arthritis. So in what way really are they different in practical terms? If you're seeing a patient with juvenile arthritis, different joints are involved. So even for the polyarthritis, which is the one that most closely resembles rheumatoid arthritis, the TMJ joint or the jaw is very likely to be involved in the juvenile population. And that's not something we typically see at all in the adult population. Uveitis being a feature of the condition, and the ANA rather than the rheumatoid factor positivity is another thing that's quite distinct. Something that is very funny actually, and you really unexpected, is that patients with very active arthritis who are of juvenile onset quite often have very little pain. So when I see a young person who's, let's say, 12 or 13, and they're incredibly articulate about pain, able to describe pain all over in really good detail. Usually I think these patients probably actually have a chronic pain syndrome rather than juvenile arthritis. The typical juvenile arthritis patient does not overly talk hugely about pain and tends to minimize symptoms, and the examination is really, really, really critical because you don't tend to hugely see them complaining of pain the way adults would. They may not even have early morning stiffness. So again, the classic findings we're used to hearing about and questioning about in adults are not necessarily there in the juvenile population. Examination is critically important, and this is obviously you want to examine all your rheumatology patients, but in an adult rheumatoid patient, for example, it's very unusual that you're surprised by what you find on an examination. A patient can tell you they have a big knee, they can tell you they have early morning stiffness, and usually you're confirming findings on examination. When you do an adolescent clinic, it's incredibly different. Nearly every clinic in an adolescent clinic, you're surprised by something you find when you examine. You have the young guy telling you, I was out windsurfing at the weekend, I was doing this, that and the other, I feel great. And then you examine and you find, 2 giant knees that don't straighten. So examination really is a very, very critical thing here relative to the adult population. Treatments also differ. So this is fundamentally something quite different from our rheumatoid population. Obviously, though, juvenile arthritis is something that will occur. A lot of our population will have this disease through adolescence. So just to spend a little bit of time talking about beyond the joints, and I guess relative to hospital doctors, our GP colleagues are very used to the adolescent cohort, whereas adult hospital grown-up doctors tend to not really fully appreciate this side of things. So adolescence is defined as the age of 10 to 19 by the WHO. It's a really unique time of diverse and rapid changes in a person's life. If you think about what happens around the age of puberty onset, physically people grow dramatically, they look different by the end of puberty. They have developed sexually, they have puberty. Socially, instead of their parents being their main influencers, peers and partners really come to the fore. And being similar to their peers is critically important. They have to face education and the tasks that go with that, state examinations, and really they have to decide what they're going to do with their lives. And really I think it's fair to say that during adolescence, trajectories are set for future success. So this is probably about the worst possible time to develop a chronic disease that requires hospitalizations, potentially medications, side effects, and pain. In addition to this, there's something very interesting about development. So we all have, 13-year-old, 14-year-olds in our practice who, if you look at them, would do for 25. They're 6'3", they're very developed, and you probably may think of them already as older than they are. But actually, the last part of maturation to occur in a normal development is the brain. And in fact, although you may be fully grown physically by 13, 14, 15, it's probably not until your mid-20s that your brain has fully developed. And the last part of the brain to fully develop is the prefrontal cortex. So this is the executive suite. This is calibration of risk versus reward. So risk-taking behavior, problem solving, thinking ahead, self-evaluation, long-term planning, and regulating emotion. So if you think of the things that an adolescent with arthritis needs to do with regard to taking medications that make them feel sick, attending clinic appointments where they might feel anxious about that, having to manage all the tasks that go with that, with taking drugs, doing blood tests, etc. This is the last part of the brain to really develop, and this is the part most useful for having a chronic disease. So to talk about that in a different way, I really love this study. This study basically asked young children, adolescents and adults a series of questions. They were a great series of questions, such as, is it a good idea to set your hair on fire? Is it a good idea to swim with sharks? There were a whole series of these questions and they were fabulous. So the child said, no, it's not. And the adult said, no, it's not. And the adolescent said, no, probably not. So they did come to the same answer, But they had a good old think about it. Is it a good idea to set your hair on fire? Well, you know, it could be a bit of fun. I'd really freak my parents out, you know. Yeah, they're not automatically coming to the answer straight away. And you know, this is something that we see in clinic, that they will probably, if you help them problem solve, come to the right conclusion. But it's not an automatic assumption to think that they will immediately think in the same way that you do. And I think this is nicely evidenced by just in general football and Premier League, where people are being paid, they're adults, they're receiving huge sums of money to go out, hit a ball into the goal and make sensible decisions and not bite their colleagues and not throw a tantrum and not get arrested. And even though it makes every logical sense to go ahead and behave in a certain way, that impulse control just isn't there yet. So if you think about this in the context of a chronic disease as an adolescence, it makes sense that adolescence is about the untimeliest period to develop a chronic disease. The disease affects normal development, so patients with JIA are at risk of growth restriction, leg length discrepancy, they unfortunately have longer dependency on parents, so the disease has huge effects on what should normally be happening, but also adolescence affects the disease. You have to deal with risk-taking behavior, which is a normal part of adolescence, but can have terrible consequences if adherence is an issue, alcohol, drugs, sex, etc. Adolescence has huge impacts on how this group of patients can be managed during this time. So what do we know about how these patients fare in the longer term? Well, traditionally, what has happened to this group of patients is that they have reached 16, or in some countries 18, they leave the paediatric service, and then they've kind of disappeared. So they appear in a normal adult clinic. Quite often, traditionally, they were relabeled as rheumatoid arthritis when they reached their adult audience. In the UK, that particularly happened because it made it easier for prescribing, because things were more compliant with NICE guidelines if an adult patient had a label of rheumatoid. So a lot of these patients, for all intents and purposes, disappeared. So we have very limited data, to be honest, about how these people fare in the longer term. What studies we do have don't show a great effect. We see huge rates of requiring joint replacement already in early 20s, and we see kind of osteoporosis and lots of end-stage damage. But hopefully in the age of the biologic drugs and things like that, good studies in the future will hopefully show a more positive picture. What we do know is that they do very well from an education point of view. They're as likely as their brothers or sisters to get to third level education and complete it. But what they don't then do is primarily enter the workforce. So while they get as far as their siblings through college, then it's trying to access employment seems to be where you see quite a significant difference. Equally, this group of patients are far less likely than their siblings to be living with their long-term partner or to in fact get married. So this is having very much significant consequences relative to their own siblings on how they're reaching adulthood, normal adulthood. Remission rates, which is what everyone used to think people would grow out of this condition, well, it looks like that's really only good for the oligoarthritis. For the other types of arthritis, they do persist into adulthood by and large and do need ongoing treatment. So what does best practice look like, or what should it look like? Well, there's very clear guidelines internationally, and most countries are doing a reasonable attempt at following these guidelines. Guidelines say that patients with new JIA should be seen by a specialist within 4 weeks. One of the big obstacles to that is what a heterogeneous disease it is. So a systemic JIA patient may just present with a rash and fevers. Patients don't expect themselves to have arthritis, their parents don't expect it, so there can be a very long lag between symptom onset and them finally reaching a rheumatologist. International standards dictate that they should be seen every 3 months. They should have ophthalmology screening regularly until the age of 14. They should be seen in an age-appropriate setting, be it pediatrics, adolescents, or young adult. They should be seen by someone who understands and knows and has a knowledge of JIA. There should be a planned transition to adult services, and the receiving rheumatologist should ideally offer a young adult clinic. This is best practice. It is what is happening in a lot of countries, and it is increasingly happening. So in Western countries, you're increasingly seeing dedicated adolescent clinics and dedicated young adult clinics. What happens here? What happens here, we read about pretty regularly in the newspapers. We're not where we want to be. So currently, there's a delay in recognition, and that's an understandable delay in recognition. No one really has it high on their list that a young person can get arthritis. There's a delay usually in seeing a rheumatologist and in accessing a paediatric rheumatologist, and I think probably the audience here are very familiar with that. There's about 500 patients, I think, currently on the Crumlin waiting list. Once you get into Crumlin, the care is fantastic. You meet patients and they are incredibly happy with care once they've managed to access the system. But at 16, again, by and large, for most patients, there isn't capacity or young adult clinics set up around the country. So with the very small exceptions of a few patients being lucky to go to the Vincent's Young Adult Clinic, the vast majority of patients are then just disappearing off into the adult world. The problem again there is lack of follow-up, lack of knowledge about the condition, lack of really understanding of the differences of the condition. So what can be done better? I think we can raise awareness about the condition. I think we need to work to have rapid access. Albeit that care in Crumlin and Temple Street is fabulous and the consultants there are really go above and beyond, as do the entire staff. There's more than a year of a wait for an MRI typically. There are delays seeing an ophthalmologist. There's limited staff, limited clinic space, not enough of an MDT, and they really are putting out fires, albeit in a really, really good way considering. Unfortunately, patients frequently describe, and the literature describes, the typical reaction of a teenager leaving paediatric care as feeling dumped and abandoned. They tend to not turn up, so they go to usually either their first or their second clinic appointment. Probably their parents are kicked out of the room. They're quite nervous. If their parents do manage to get into the room and dare to ask a question, that's quite often not very well received. Quite often these patients are not seen again by the rheumatologists for another 3 or 4 years, at which stage the disease has progressed. There's damage that could have been avoided. So I think there's huge scope to do this really well and really nicely, to have special clinics with adolescents in mind, special clinics with young adults in mind, and really give these patients the service they deserve. So in Blackrock, we have the very luxurious ability to have access for those patients who want to come. We have the relevant specialities, including orthopedics, radiology, and a really great MDT. And I'm hoping over the next period of time to develop an adolescent and young adult centre for chronic diseases from JIA, but also JSLE, CRMO, juvenile dermatomyositis, etc. With regard to just the young adults clinic, to just say a word about that, these are some quotes from my patients who attend a young adult clinic they're my patients from the UK. Things they say is, being in a specialist young adult clinic is essentially very much wanted by young people. They want to feel that we understand their day-to-day lives. We understand they face different problems to the other patients who look very old to them, who are sitting in the waiting room. They want to know they're not the only young person with this. They say they're not as worried about leaving the paediatric setting if they know they're going to a young adult setting. So this is important to young people. So young adult services are dedicated services for those basically who have finished secondary school and for kind of to follow them up for the next 5 to 7 years until they're independent in self-management, care, and really have completed a proper transition whereby they're actively managing their own health entirely. The hallmarks are the ability to access, having age-appropriate care, and being able to provide continuity and being able to tailor a service towards a young person's need. And the aim really is to allow these young people to reach their full potential. So, to sum up, juvenile idiopathic arthritis is not just mini rheumatoid, it's a heterogeneous group of conditions. Clinical features vary widely depending on the subtype. It differs from adult arthritis. Adolescence is about the worst time to develop a chronic illness. Currently, there's lots that's being done heroically in the Irish services, but waiting lists, lack of ability to access tests and ophthalmology service, and the lack of receiving young adult clinics is a significant hurdle to good care. And in the context that most patients do require into adolescent treatment into adulthood, I think there's lots that can be done. So thank you very much.
So Dr. Ambers, thanks for a really interesting and informative talk, a lot of new information there. I was just wondering, I suppose, it seems that the presentation can be quite subtle, and I imagine maybe that's why cases aren't necessarily picked up. But given that the kind of early access is so important, are there any particular red flags that might help to alert, maybe other than uveitis?
So the things to think about in the younger child is a step back in milestones. So a child who was walking and is not walking. The hard thing is that quite often these patients don't have the vocabulary to express pain. Or they don't express pain. So looking at the joints, a restricted joint rather than a swollen joint is the key finding. So in juvenile idiopathic arthritis, you might find that actually it's not a huge hot red joint, although it certainly can be, but a joint that doesn't fully straighten or doesn't fully bend is really suspicious for an inflammatory process going on. They have something called dry synovitis, or CANDU, which means that it's not like an adult rheumatoid joint that is full up of fluid and feels really big and watery. They can have a joint that's not hugely large, and you're feeling into it and it feels like tissue. It's not that kind of fluid, but it won't straighten fully, it won't bend fully, and that's very suggestive of inflammatory arthritis. The systemic JIA is difficult to recognise because it can present with high fevers, patients being acutely very unwell. They usually end up needing admission for a PUO workup. And in the context of fevers, you then have to think about it, and the raised ferritin is the hallmark there. As patients get older, a young male with back pain, so an adolescent with back pain raises the suspicion of ERA. The girls tend to get more the small joints of the hands, arthritis in teenage years. What I would say though is the typical patient who I see who can spend 5 good minutes describing their pain is much more likely to have a chronic pain syndrome than to have an inflammatory arthritis.
Okay, thanks for that. Are there any questions? And for the audience joining us on the webinar, they can email questions, which will be dealt with as well. Does anyone have any questions? I was also wondering, I suppose if we were suspecting it, I suppose if clinically it was suspected, it sounds like we should refer promptly, but presumably we could initiate some radiology and autoantibodies and so on.
Yeah, and again, the thing that sometimes I see is that people think to do the rheumatoid factor, but they forget to do the ANA, and it's the ANA that's much more likely to be positive in this age group.
And does CCP have a role?
CCP can be positive in a small set of them, but more likely to be the teenage girls.
Okay.
So I'd say do the ANA, the rheumatoid factor, your autoimmune screen that you would do to think about other conditions as well. If there's any sort of a rash or any sort of things suspicious of fever is add in the ferritin, the normal inflammatory markers. And then I think, given the waiting lists in Crumlin, I think how your letter looks is probably incredibly important, because they really have to be ruthless on their triage, I imagine. So if you think that they have 500 people on their waiting list, I think describing a restricted joint, a swollen joint, having done the bloods or the x-rays, I think you're more likely to get the access you need. Yeah.
Great, thanks. I think there's a question there in the back.
Thank you. In a patient with oligoarthritis on methotrexate and free of symptoms,
Pardon?
with no symptoms,
Yeah.
what helps you decide when to stop treatment with such a high risk of recurrence? Like, is it just a time thing?
With the oligoarthritis, is it? So the reason to treat an oligoarthritis, so let's say they have a very large knee or something like that. So albeit they're not reporting pain, you'll find that the parent is telling you they're exhausted, they're irritable, there's clearly something going on, they're not themselves. Non-treatment is going to lead to joint damage. Also in a joint, like during growth, you have to think about the growth plates, and an untreated, let's say, swollen knee is likely to lead to a leg length discrepancy, which can be really dramatic as well. There's good evidence to say that after initiating biologics in patients with JIA, just quite broadly labelling them there, there's catch-up in growth. So the non-thriving child who's treated aggressively, rather than that being something to be worried about, you're making them healthier. You're allowing kind of catch-up growth, catch-up milestones. So really, I think, rather than a watch and wait approach, which is what we used to do, and I think what we used to do on the adult side as well, that's kind of flipped on it entirely, and now it's about aiming for remission, aiming for no disease activity, to allow these people to grow normally and to develop normally. Did that answer the question? Not quite?
No. I mean, if at some point they're going to be symptom-free if they have oligoarthritis and they're on methotrexate. So let's say they're symptom-free.
Oh, yeah. And when to
they've
stop,
been
is it?
like that. Yeah, what helps you determine when to stop?
Oh, sure. Okay.
Is it just waiting for a certain number of months, or is there anything else that you look for? Thank you.
So if you have any of the JIA conditions, particularly oligo, step one is to get them into remission. And so for oligo, it might just be joint injections rather than methotrexate if there's just a couple of joints in there. They're big ones you can access. But if you've started methotrexate for any of them, what you want to have is remission for 2 years. And then you taper and see. One of the areas that really needs to be explored on the research side is how to know who's going to flare and who's not. So we know, for example, if you're a teenage boy with back involvement, you're highly likely to flare, you're really unlikely to successfully wean, but you might be able to taper a little bit. So you might be able to get the Enbrel from every week to every 2 weeks, which is still having the medication load. But we know those patients usually by a year will have had a significant flare up again. Whereas for some of the other types of arthritis, you can be a bit more optimistic, and certainly if someone is in remission for 2 years, I think you should start tapering and weaning. And then it's just actually informed consent, because 2 years is very arbitrary, but if their junior cert is a month later, that's not the time to wean. So it's about also looking at their life, what's going on, and when they're willing to gamble. Because it is a gamble at the moment, because we don't have enough evidence to say exactly who will flare and who won't.
Thank you.
Yeah.
Thank you. If I might, I have 2 questions. The first one is to do with radiation treatment for joint disease. And the second is, I see a bit of Lyme disease. Would you care to say anything about that?
How do you mean radiation treatment for bone disease?
Hello? Yes, it's working. Sorry. Radiation treatment for inflammatory joint disease was the standard up to the late 50s, when corticosteroids were introduced.
Yeah.
It's still widely used, particularly in Germany. both intra-articular injections and both radiation. The European Medicine Association guidelines, or I think the last edition was 2003.
Okay, I would actually probably defer to your own knowledge there, because I have no experience at all of using radiation treatment to treat JIA.
Yes, it's a bit of a habit in the UK and the US and Ireland that we don't use them very much, but for chronic, difficult to treat cases, the Germans find it very effective and people are referred there regularly from elsewhere, just to say it's an available service. The other question, which might be more used to, would be Lyme disease. I see some of it from time to time. It certainly seems to be a bit, it comes up. We certainly see the rashes and the arthritis and the bits and bobs. It certainly seems to be more common these days.
It's a controversial question, Lyme disease, because I think there's Lyme disease and there's the many patients who don't have typical presentations of Lyme disease who receive treatments. I'm very conservative, I think, in my approach to Lyme disease. I think if someone hasn't been in a region that would make me suspicious for it and had a bite that they recall, etc., unless they're serology positive, I wouldn't like to assume that antibiotics are going to be the solution. I think it's quite a controversial area, and probably beyond the scope of this talk on JIA, though.
The problem is it does cause an inflammatory arthritis. It does occur in juveniles. And I agree with you entirely about the serology. I wouldn't treat them with it either without the serology being positive, but I do see some.
Yeah, absolutely. And in those cases, it's fabulous being able to offer a cure. The downside is it's been a condition that I think has been commandeered by a cohort of people who I would have a different practice to.
I would agree with you.
Yeah, JIA before we introduce our next speaker. Any questions from our webinar audience?
I'm doing my second.
Oh yes, sorry. Yes.
Yeah, I have a quickie.
Yes.
So we're each just doing a quick hot topic. Yeah, I'll do that. I think that's the way things have been loaded up. So we said we'd each give just a very quick little thing about just whatever hot topic sprung to mind. So my hot topic is capturing the fracture. Capture the fracture. So bone is lost from, so here is a nice picture of trabecular bone, the middle part of bone. You'll all know it's surrounded by the very dense cortex. Bone is lost from this inner part before it's lost from the outer thick cortex. Different bones contain different amounts of this trabecular part. So what we see is when patients have low bone mineral density, that they've lost calcium from this part. We see that if they're very young, they fall, but they have a protection mechanism, so they break their radius. When they're a little older, the vertebrae have lots of this trabecular bone, so they have vertebral collapses. And the final series of events in this series is that when they are a little older and have a degree of frailty, they may lose their fall protection mechanisms, and that's where they fall sideways onto their hips and fracture their hips. So there's a series of events where quite often the same person is having, in their youth, a wrist fracture, in middle years, a vertebral fracture, and eventually leading on to a vertebral fracture or a hip fracture. So what we know is fractures beget fractures, or fractures predict fractures. So if you have a wrist fracture, there's a threefold increase of a further wrist fracture. But there's also hugely increased risk of vertebral fractures and hip fractures in the future. Equally, if you have a vertebral fracture, you're more likely to have hips, vertebral and wrist fractures, etc., etc. If you have a hip fracture, you're much more likely to have a hip fracture. So if you can intervene optimally following the first fracture, you can reduce the risk of the second fracture by 50%. So on the back of that, what we see is that patients come, if this is morbidity, and normal morbidity going up with age, we see that these little spikes represent the first collis fracture, the vertebral fracture, the vertebral fracture, the vertebral fracture, and the hip fracture. And really, there is now, on the basis of this and the 30-year journey of people's bones, a trendy thing called a fracture liaison service. So a fracture liaison service is endorsed by everyone. It's endorsed by all the national, international osteoporosis societies, by NICE, by orthopedics, endocrinologists, rheumatologists, gerries, everyone's on board for this. And if you look at any of the fracture liaison service literature, you see a nice stamp from every society out there, essentially. This is an easy win. It's a win for health economics and also for frailty prevention. 42% of UK health services now have some degree of a fracture liaison service, and it's growing really fast. If you go to rheumatology meetings at the moment and you go to anything about osteoporosis, it's all fracture liaison service. So fracture liaison service is about finding the patients with the first fracture and stopping them having the second, third and fourth fractures. It's identifying, then investigating, educating, intervening actively, and working across specialties and between hospital and primary practice. So identifying, so proactive identifying people. So all fractures over 50, fracture liaison services say should have a bone health assessment. That is, any and all fractures from standing height should have an assessment. This includes all vertebral fractures. And the reason I've put the little asterisks here beside the vertebral fractures is what I find and what is reported very broadly in really good institutions is that when vertebral fractures are noted on imaging, CT thoraxes and chest x-rays done for other reasons, they're only mentioned about 40% of the time. And rarely, if ever, do they get a line in the conclusion. And rarely, if ever, is there a recommendation for action to be taken, such as a bone health assessment on the basis of it. Fracture liaison services endorse actually a complete change in that, whereby it creates an alert if a vertebral fracture is picked up. And best practice says that we should be paying attention to these because they're usually missed, ignored, when they're picked up as incidental findings. So what they're saying is identify proactively all the fractures over 50 years old, in people over 50 years old, particularly vertebral fractures, in a view to then finding people at high risk of hip fractures before they have their hip fracture. Investigate, so get a bone health assessment, do a falls risk, see within 3 months when the bone health service. Intervene, so medications, but also falls protection, education, diet, lifestyle, and integrate. So this is something that's quite, in a lot of centres, being led by rheumatologists, but actually this is something that should be integrated between all of the relevant specialities, particularly orthopedics, primary care, emergency departments, radiology, etc. The fracture liaison service guidelines say reassess in 4 months, and that's because adherence is such a major issue with these drugs. And that may relate to lack of understanding or drug intolerances or concerns. And then it says, look after them annually. It works. So great evidence to say you get a 50% reduction in all fractures by identifying the first fracture and a 25% reduction in hip fractures. So capture the fracture is my short, hot topic take-home message. Okay? Yeah.
Thanks very much, and yeah, definitely an important message to take home. So I'd like to introduce our next speaker. So Dr. Richard Conway is also a consultant rheumatologist at Blackrock Clinic. Certainly, yeah. So Dr. Conway is a graduate of RCSI. He completed specialist training in both rheumatology and internal medicine. His areas of special interest include early onset arthritis, rheumatoid arthritis, giant cell arteritis and vasculitis, and osteoporosis. So we're looking forward to your talk, Dr. Conway. Thank you.
Good evening, everyone, and thank you all for coming either in person or online to listen to me talk. I'm going to start off with my hot topics, short topics, and then go on to my main presentation. And I've decided to talk about two things, and there are two questions I've been asked a lot recently in practice, so I thought it'd be useful to go through them. So this is the first one, and this is about febuxostat and whether or not it kills you, essentially. So this is the CARE study, which was published last year in the New England Journal. And essentially, a picture paints 1,000 words, so particularly looking at the bottom two graphs here. You can see that the lines are diverging clearly, only a small bit, but they are diverging. And those two graphs are for cardiovascular mortality and all-cause mortality, and they're comparing febuxostat and allopurinol. And what they're saying is that there appears to be this small but significant increase in mortality with febuxostat compared to allopurinol. This doesn't tell us if allopurinol is good, if febuxostat is bad, or if in fact they are both good and one is better than the other, or they're both bad and one is worse than the other. If we look back at a different trial to try and think about why this might be. So this was the original febuxostat trial. This is about 15 years ago, the FACT study. And what's happening here is at the start of this graph, people are being commenced on either febuxostat in 2 different doses or allopurinol at a dose of 300 milligrams. And they're looking at their flare rate over time after they start this, so their rate of gout flares. And in the first part, there are not that many flares, and that's because they're all in prophylaxis with colchicine for that time. Then the colchicine stops, and there is an increase in flare rate for the 3 groups, and the height of that is essentially proportionate to how rapidly the medicine lowers the uric acid. So the lowest is with allopurinol 300 milligrams, and then with febuxostat 80 milligrams, and then febuxostat 120 milligrams. Febuxostat only comes in these 2 doses, in Ireland at least. Allopurinol comes in lots of doses, and certainly my practice is not to use this dose at the start, it's to use 100 milligrams as a starting dose, and that's because the 100 milligram flare rate is down here somewhere. So the quicker you lower the uric acid, the more flares you get. And why that might be important to cardiovascular risk. This is a study we did a couple of years ago now, and this was looking at platelets in patients with gout. And what we showed in this is that platelets in gout patients, and particularly in flaring gout patients, are hyperreactive. And we know from other studies in myocardial infarction that's associated with an increased risk of cardiovascular events and of mortality. So my feeling is that this might be the explanation for why febuxostat, especially at high doses, and the quicker you lower uric acid, might be associated with an increased risk. So the way I interpret this data, thankfully I haven't had many people ask me this, because I have traditionally used very little febuxostat because I feel that allopurinol gives you a lower, smoother route with less flares to achieving your goal. But I think particularly based on this, we should use allopurinol as our first line gout urate lowering therapy. We should start at a low dose of 100 milligrams and increase this slowly by 100 milligrams a month until we get to our target urate, which is, for most people, is less than 360. For people with really bad tophaceous gout, we aim for less than 300 to try and get rid of those tophi. I personally use prophylaxis for 6 months at least, and generally I use it for 6 months after I achieve my target uric acid to reduce this risk of flares. There's not particularly for this reason, but if people flare when they're on their treatment, they have a tendency to stop it, and then we never properly treat the gout. So if they stay on the colchicine or prednisolone for the 6 months, they tend to have a much lower rate of flare and are much more adherent and happy to be on their treatment. I don't think we have to forget about febuxostat. I still think it's a valid option in people, the unusual people who allopurinol is not suitable for whatever reason. The second thing, which I have had even more questions about and more problems because of, is denosumab, and denosumab being stopped. So we know for bisphosphonates, drug holidays are used and are appropriate in certain patients. So after somebody's been on the bisphosphonate for a prolonged period of time, the bisphosphonate gets into their bones, it sits in there, it continues to have an effect for many years after it's stopped. So they don't necessarily get ongoing benefit by continuing to take the drug. This is not true with denosumab. Intuitively might think it is, because denosumab is a 6-monthly injection. It should last for a very long time. But really, as soon as that 6-month period is over, the effect of denosumab drops off quite quickly. So the top 2 graphs here are showing what happens to bone mineral density, and this is comparing denosumab, which is the upper line, to placebo, which is the lower line. So with the denosumab, there's a big increase in bone density while you're on it, and this blue is after the denosumab stops. There is an even more rapid drop in the bone density after denosumab has stopped, and other studies have shown that is proportionate to an increase in fracture risk when the agent is stopped. And again, just to compare that in the lower slides with alendronate, you don't see this drop off. It continues to have or sustain its increase in bone mineral density over time. So what I would take from this is that denosumab does have this rapid off effect after its 6-month period is up, and that is associated really with a catch-up in fracture risk. So what I tell patients that all the fractures you are going to have while you are on this medicine may well happen if you stop it very quickly. So I don't think denosumab can be stopped unless it's replaced with something else. The something else is it can be replaced with either more denosumab to keep it going or a bisphosphonate, and that should maintain bone density. Arguably based on this and other reasons like costs, we would say that oral bisphosphonates should be the first line treatment for osteoporosis. That isn't necessarily what I do. I probably use equal amounts of an oral bisphosphonate and denosumab, and the reason I do that is because of this, which is looking at adherence to bisphosphonates. So we know that in general patients aren't always adherent to medication, but it's particularly bad for agents like bisphosphonates, which you can't really see the effect of and are also slightly difficult to take. They're an awkward medication to take. So the adherence rate for a weekly oral bisphosphonate is about 40% at best over time, and if people aren't taking the drug, it's not going to work. The one good side of denosumab is that you know somebody's getting it because you're giving it to them yourself. And there are all sorts of ethical issues about that and what patients should be able to choose to adhere or not. But I'm quite open to people about the good sides and the downsides to these two medications, and essentially let them choose themselves a lot of the time which agent they prefer to be on. So I'm going to go on and talk about my main topic, which is about joint cell arthritis. You might ask, why am I talking about this? For a few reasons. I think joint cell arthritis, it's a common condition. So in Ireland, your lifetime risk, if you're a woman, of getting joint cell arthritis is 1%. So this is not a rare disease. And it's a serious, potentially devastating disease. 25% of patients will get permanent vision loss or stroke due to joint cell arthritis. The diagnosis of joint cell arthritis is changing. It's questionable whether that should be happening or not, but it certainly is, particularly in the UK, and I'll go on and talk a little bit about that. The treatment is most definitely changing, and we, for the first time now, have treatments other than steroids which work for joint cell arthritis. And ideally, we want to see these people really rapidly for all sorts of reasons. Most importantly, perhaps, was the diagnosis becomes more and more difficult with time, and also because they tend to get more and more adverse events due to steroids over time. And if we can do something different early on, if that's appropriate, then we should do that. So joint cell arthritis isn't a very old disease. This man here is Bayard Horton. He was the first to describe joint cell arthritis in the early 1930s. It wasn't declared a disease properly until the editorial up here, which was in JAMA in 1946. And steroids were first used in joint cell arthritis in 1949 by Horton. And until the last couple of years, really not much has changed in our treatment of joint cell arthritis. This was still, and still is, predominantly based on steroids. And steroids, for all their downsides, they do work well for this condition. So the note down the very bottom of the slide here is from Horton, and he was describing his first 99 cases of giant cell arthritis. And of those, he said that 35 had permanent vision loss, and 23 of those 35, it was bilateral permanent vision loss. And that, especially the bilateral nature, is not what we see. We probably still see this same amount of unilateral visual loss at presentation, but thankfully with steroid treatment it's highly unusual to see bilateral visual loss over time. Joint arthritis is a slightly unusual disease in that it has a very striking incidence change based on your latitude. So this is data where it's available for Europe, and it's color coded. So going from more common to less common, it goes red, blue, green, yellow. Ireland we don't have any data. We believe from the work we have done in it, that Ireland is probably red, not blue like the United Kingdom, and that's because Ireland as a country has a much more homogenous population. We have much less immigration from areas with very low prevalence of joint arthritis, so it's vanishingly rare in Africa, in the Caribbean, in the Indian subcontinent. Now we are seeing more immigration in Ireland now, and as are the Scandinavian countries, but for now we think certainly the incidence remains very high but under-recognised within Ireland. So I said joint arthritis is a common disease. Lifetime risk in Ireland of 1% if you're a woman and 0.5% if you're a man. I ran a joint arthritis clinic in St. Vincent's Hospital. We were seeing 90 new patients a year with joint arthritis. So it's an underdiagnosed condition, and the care is also very uncoordinated. Patients go to various different specialties in various different hospitals for bits and pieces of their care, and there hasn't really been a proper coordinated service for these people with this high-risk disease. So this at the top is my crude drawing of a larger medium blood vessel, and I've put this up here because I think I need to talk very briefly about the pathogenesis of this condition to explain why we've had so much difficulty treating it mainly. So we think in joint arthritis the problem actually starts out here around the base of vasorum and at the interface between the adventitia and the media. And out there are cells which are called dendritic cells. They're part of the innate immune system. They're watching for dangers to the body and the artery. And something in joint arthritis triggers them and sets them off. We don't know what that is. We don't know if it's an exogenous thing like a virus. We don't know if it's an endogenous thing like a danger signal or a cytokine from the body. But whatever it is, when the dendritic cells get triggered, they release a flood of cytokines themselves, which then activate two different T helper lymphocyte subsets. T helper 1 cells, which we think are responsible for the ischemic manifestations like vision loss and stroke. And then there's T helper 17 cells, which we think are responsible for polymyalgia, for patients feeling generally dreadful, and for the raised inflammatory markers. And trying to target this dual pathogenesis, we feel, is part of the reason why it's been so difficult to treat this condition. So I've put this up because certainly when I started out doing joint arthritis work, both in the clinic and research, I had no idea what joint arthritis looked like in a blood vessel or what a giant cell was. So this is a normal artery to correspond with my drawing, so intima, media and adventitia layers. I think the other ones are all abnormal, but we'll concentrate on this one, C. So the yellow arrow is pointing to all these little black cells. These are lymphocytes, which are invading into the media from the adventitia. And the green star is showing intimal hyperplasia, so the intimal layer growing in and across the lumen and blocking off the artery. And down here, this fella here, shown by the other yellow arrow and blown up here, is the giant cell. So this is the giant cell that we see in joint arthritis. We don't see this in all patients with joint arthritis. We only see it in about 20% of people who actually have joint arthritis, but when you see it, it's very pathognomonic of the condition. So classically, joint arthritis has been mainly considered as this cranial joint arthritis, so that's a patient with headaches, vision loss, raised inflammatory markers, but it's actually a much wider group of conditions. I consider polymyalgia rheumatica to be on the same, at different end of the spectrum of joint arthritis as this form. I think they're the same condition. Polymyalgia rheumatica is almost a form fruster, an incomplete version of it, but having the potential to develop full-blown giant cell arthritis. And then there's other subtypes, so patients have an increased risk of stroke, and it can have a stroke purely because of giant cell arthritis. They can have predominantly constitutional disease, or they can have what I've called difficult PMR, which I'll talk about again. So classic giant cell arthritis, I think we all know, a typical elderly person, more often a woman, has had bad headaches for a little while, might have a bit of scalp tenderness and a sore jaw, but they're only headaches, she doesn't do anything about it, and then loses vision. And then she gets lots of steroids, which protects her other eye, but doesn't do anything for the eye that's already been affected. Difficult polymyalgia is distinct from normal polymyalgia. So this I use to mean a typical person where they go on steroids, they get a bit better, or completely better, then steroids come down and the pain comes back, and they go back up on the steroids, the pain goes away, the steroids go down, the pain comes back, and there are lots of reasons that can happen, but one of the common ones is that they don't have polymyalgia rheumatica at all. What they actually have is large vessel involvement from giant cell arthritis, so their aorta, their subclavian artery, their axillary artery are involved with giant cell arthritis, and they respond partially because the steroids suppress that inflammation, but they don't do anything to clear it. It's not a high enough dose, so they end up jumping up and down on steroids repeatedly and never able to get down to anywhere near a safe, tolerable dose in the long term. And perhaps the patient group which are the biggest problem of all are the slightly younger patients, often of working age, who will come in with essentially a pyrexia of unknown origin, and they'll have high inflammatory markers. We won't really know why, and these patients end up getting very extensively worked up often before some tests might show inflamed blood vessels. Depending on where you work, that could be a PET scan that's done to look for malignancy. It could be a CT angiogram done to look at the blood vessels themselves. I'm not sure what the right answer with these patients is, because obviously when they first present they can have lots of other conditions causing this that do need to be checked out. But at the end of the day, these people, if they are diagnosed as giant cell arthritis, which is not an uncommon diagnosis for them, they also end up getting lots and lots of steroid. The other problem with these is that if you do a temporal artery biopsy as your test of choice, it probably won't show up because the temporal artery is not involved in a lot of these patients. So, as I said, giant cell arthritis is a potentially devastating disease. The picture of the fundus here is an ischemic optic neuropathy caused by giant cell arthritis, essentially irreversible once it happens, leading to permanent blindness in that eye. The MRI scan is showing a posterior circulation stroke, so particularly posterior circulation strokes is what we see in giant cell arthritis. Those patients tend to get visual symptoms as well, and ataxia, balance problems. Don't tend to get hemiparesis like a typical stroke. And even in the longer term, with well-controlled disease, the X-ray here is showing a thoracic aortic aneurysm. So giant cell arthritis patients are at increased risk of developing these over time, up to a 10-fold increased risk, and this is associated with sudden death. Very few of these patients will be fit for surgical intervention for these aneurysms. This is a very busy slide. It's really up just to show that there's a very large variation in estimates of how frequent symptoms are in giant cell arthritis. We've looked at this ourselves. So not everyone with giant cell arthritis gets a headache. About 3/4 of patients do. Interestingly, about 3/4 of them also get at least some form of constitutional symptoms, at least a fever or a sweat or weight loss because of their disease. Up to 50% will get visual disturbance, so they can get transient vision loss, amaurosis fugax or diplopia or something other than permanent vision loss, and that is a herald of developing more serious visual complications down the line. The 50% of patients get polymyalgia rheumatica either at the start or sometime during their disease, and jaw claudication, up to 35% of patients get this, and that's important. So I've just picked out a few points from the giant cell arthritis history which I think are helpful for suspecting it or suspecting it's not giant cell arthritis. So jaw claudication is the most specific symptom for giant cell arthritis. That is pain in the jaw that develops while somebody is eating. So typically, at least early on, at rest, they have no jaw pain. And then they'll get pain in the mandible and masseter as they chew, and it is the same as claudication elsewhere. It gets worse and worse and worse. They have to stop because of it. And then they can restart chewing again, and the same process will happen. Sometimes in very late disease, patients can have pain in their jaw at rest, but that is more typical of other jaw disorders like temporomandibular dysfunction or non-joint cell arthritis causes of jaw pain. Amaurosis fugax is a reasonable predictor of joint cell arthritis. It's certainly a predictor of something bad going on, whether that's an embolic phenomenon or joint cell arthritis, and so absolutely shouldn't be ignored. In joint cell arthritis, most patients who get permanent vision loss will have amaurosis fugax first. They'll have transient episodes before their permanent loss of vision. Neuropathic pain or neuropathic headache is a negative predictor of giant cell arthritis. It's much more likely to be caused by something else, either migraine, trigeminal neuralgia, occipital neuralgia. It's not a 100% thing, as some patients with giant cell arthritis, particularly over time, will develop a secondary neuropathic pain due to irritation of the nerves around the temporal artery. So it can't be trusted completely, but it would always make me think again if someone was reporting a lot of burning or paresthesia associated with their headache. The clinical examination in giant cell arthritis, it would be nice if it gave us an answer, but unfortunately it doesn't always. It can be completely normal in somebody with very severe disease that's going to lead on to vision loss. And it can also equally be highly abnormal. So patients can come in with giant cell arthritis who look for all the world like they have metastatic malignancy. They can look that unwell. Temporal arteries are what we tend to focus on. Sometimes it's very easy and the artery is rock hard and swollen and there's no pulse present there. But more often or not, there's a little bit of maybe the pulse is a bit down, maybe the artery is a bit tender, and we're not really sure what to make of that. Bruits in the large blood vessels can be a useful sign for giant cell arthritis. They're also seen in atherosclerotic disease, so there is an overlap. I would always listen to them. So the subclavian artery under the subclavian and the axillary artery in the upper arm. And if I hear a bruit there, which tends to be a very distinctive bruit, those bruits tend to be much louder than a carotid bruit would typically be, I would send the patient for some form of large vessel imaging study, usually a CT angiogram, to clarify exactly what was going on there. More rarely, patients can get things like reduced pulses or blood pressure difference between the limbs, but it's actually very uncommon, at least in early giant cell arthritis. Now, unfortunately, we don't have a diagnostic test. We don't have one test that's going to tell us that this is what the patient presenting to us has. The 1990 American College of Rheumatology criteria for the classification of giant cell arthritis, I have deliberately not put up there. We probably all know them. They're the 5 typical things of headache, raised ESR, a positive biopsy. You only need 3 of them to meet the criteria. And essentially, if you're elderly, you have a headache, and you have a high ESR, you meet the criteria already. So it doesn't matter what that is from, if it's from sinusitis or meningitis or the flu or a brain tumor or giant cell arthritis, you will still meet the criteria. So these are probably the worst thing that ever happened to the diagnosis of giant cell arthritis. They were not meant to be used for diagnosis. They were meant to be used for research purposes to stratify patients who you knew had vasculitis into a particular form of it. They're also outdated and they're being revised at present, even for the classification purpose, but they are close to useless for diagnosis, and they'll both overdiagnose and underdiagnose large amounts of people. The temporal artery biopsy, if it's positive, is the most useful test because the patient definitely has vasculitis and they almost certainly have giant cell arthritis, but it's only positive in about 50% of people at best. So the other 50% are a problem. I said that the diagnosis of giant cell arthritis is changing, especially in the UK. What it's changing with is temporal artery ultrasound scanning, and there is huge political pressure to make this a thing in the United Kingdom, huge proponents behind this for all sorts of reasons. And there are people going around suggesting you just need to do this ultrasound, you don't need to do biopsies on these patients, you can make the diagnosis with this one test. I don't think the data backs that up at all. The data up here is from the study done by all the experts in the UK. It's called the Talbot study. So these were the people who were advocating for it. It also had a sensitivity of about 50%, not necessarily overlapping with the biopsy 50%. If you do both, it brings it up to about 70%. More worryingly, its specificity is only around 80% in that study. And that means that 1 in 5 of the positive ultrasounds you have is wrong, and the patient doesn't have giant cell arthritis. So it's very hard not to treat somebody with a positive test like that. So that often means that 1 in 5 patients are getting treated with steroids at high doses for a condition they don't have because of this positive ultrasound. What I've shown just below it in the box here is our data for this. We had 150 patients we did an ultrasound and a biopsy on with giant cell arthritis or not. Our specificity was even lower. So our specificity was down to 70%. So that's nearly a third false positives. And that's to be expected. This study, the Talbot study, was a randomized controlled trial done under extremely rigorous conditions. In the real world, every treatment or every test doesn't perform as well as it did in a controlled trial setting. There are a lot of proponents of other modalities for the diagnosis of giant cell arthritis. Most of these are completely impractical. So doing an MRI on everyone you suspect has giant cell arthritis. As Nikki said, in Crumlin, the wait list for an MRI is a year. In many of the public hospitals, it's getting up to 2 years. You can't be doing that sort of investigation to diagnose a condition that needs to be treated as an emergency. This is temporal artery ultrasound. So this is one of my patients. And at the top are her right temporal arteries, at the bottom are her left. The top is normal. So what you're looking at here, this red stuff is a Doppler signal, and helpfully the Doppler signal represents blood in the temporal artery. And around the Doppler you can see this grey stuff, which is the skin and subcutaneous tissue and fat and all the normal things that are around the artery there. And you can see there's no space between them. So the grey and the red are right beside each other. And again, there's no space here. But when you look at the left side, there is a big black area between the blood and the grey stuff. We don't know exactly what this represents. We think some people have suggested it's perhaps edema in the vessel wall. But it is the sign people are looking for in temporal artery ultrasound. It's called a halo sign. This lady went on to have a biopsy and it was positive in her left temporal artery. But again, this is the sign that has the caveats I've mentioned when you're looking at temporal artery ultrasound. So to go on to treatment, which absolutely is changing for giant cell arthritis. So since 1949, the treatment was based on steroids, and everyone will still get steroids, hopefully not quite as much as we used to. We don't know how much steroids to give people with giant cell arthritis. We never have. We think that more is better, but that is based on very, very loose evidence. But that has meant we've tended to give people enormous doses, both at the start and then cumulatively over time. And they end up getting a median dose of 6.5 grams and being on them for a duration of 2 years. That's a huge amount of steroids with a huge amount of side effects. Patients frequently have flares of giant cell arthritis while we're tapering their steroids, while we're cutting them down. And if they do, they get bumped back up on their steroids and get even more steroids. And many patients, either because their giant cell arthritis is coming back or just because they've been on steroids so long, we can never get them off steroids, so they stay on maintenance, long-term doses of steroids with some, less, but some side effects from these lower doses. So this is what I have tended to do for giant cell arthritis. So I take a decision point based on whether the patient has vision loss or stroke or not. If they have vision loss or stroke, I tend to give them intravenous methylprednisolone, a gram a day for 3 days. So that's another That's 3 grams of methylprednisolone, which is even more when you convert it to prednisolone, so 3,000 milligrams. So an enormous amount to give them at the start, but we do that to try and protect the other eye or protect them from another stroke. We don't really know if that actually works or not. There's some weak data suggesting it might, so that's what we've tended to do. After that, I give these people 60 milligrams of prednisolone a day for a month, and then start to cut them down similar to the other regime. So if they've no ischemic manifestation, I tend to start them on 40 milligrams of prednisolone daily for a month, then cut them down by 5 milligrams every 2 weeks until they get to 20 milligrams, then by 2.5 milligrams every 2 weeks until 10 milligrams, and then very slowly by 1 milligram a month, because that's when people are most likely to flare. So again, I think that just reflects the astronomical doses of steroids we give to these people. And the problem with that is that steroids cause an enormous amount of side effects. So I have almost stopped going through the different side effects steroids might cause for my patients. I generally tell them that if something happens while they're on these doses of steroids to come talk to me, and that it's probably the steroids, and we can probably do something about it. But until people get down to lower doses of steroids, anything that's happening to them is probably due to them rather than something else, or rather than due to their disease coming back. The other problem is that these patients with giant arthritis are generally the ones you really don't want to be giving steroids to, because they're the ones who are already prone to getting side effects from steroids. They tend to be elderly, they more often female. They often will have a low body mass index to start off with because of weight loss due to the catabolic stage of giant arthritis. They'll often have multiple other problems due to their age. Both the giant arthritis, polymyalgia spectrum can cause a myopathy, and the steroids can cause a significant myopathy, which makes you more likely to fall over, which leads on to the other big problem with steroids of breaking bones. So everyone who goes on steroids at giant arthritis doses gets some sort of side effect. For some, it can be a mild bit of hypercortisolism. They might get a bit bloated, they might have a bit of difficulty sleeping. But this study I'm quoting here says 86% getting specific nasty steroid side effects. The same group have gone back and done another study, and over a bit longer duration, they're now up to 95% getting specific side effects. And these aren't minor things. These are very, very serious complications from the steroids. So things like fractures, sepsis, hypertension, diabetes, GI bleeding. Cataracts you mightn't think would be a huge problem, but cataracts, if you can't see, you're also more likely to bump into things and fall over and get fractures. They can occur at any time on the steroids, but tend to occur at a median of a year. So naturally, the longer you're on them, the more likely you are to have a problem at high doses. I just briefly looked at fracture to emphasize how serious these complications are. So this is hip fracture. If you have a hip fracture, your chance of dying within a year is 20%, and your chance of being not able to live your life as you did before is 80%. So it's a very serious event in somebody's life. And it's not just hip fracture. So this is 5-year mortality data after hip and vertebral fracture. And hip fracture is slightly worse, a mortality of 50% after 5 years, but vertebral fracture also isn't great, about a 40% mortality after 5 years, and both of them are about 10% increases from what would be expected for the people who suffer those events. So in my time working in joint arthritis, I've just picked out a few of the more horrendous complications we've had to emphasize how bad steroids can be. So we've had innumerable patients with fractures. A record was somebody who came in with 6 simultaneous vertebral fractures in their spine. That lady ended up in St. Vincent's initially, and then in a rehabilitation hospital for about 6 months. And all the attendant suffering for her and the cost to the medical system because of these fractures due to her steroids. We've had a few people with pneumocystis jirovecii pneumonia. That's a devastating complication, mortality rate in non-HIV patients like these of about 40%. I toy with the idea sometimes of putting these people on Septrin as prophylaxis against it. Septrin can also have side effects. So it's not something I routinely do, but would sometimes consider it if somebody is ending up on very high doses for a very long time. It's not the only opportunistic infection we see, so we've had a few people with cytomegalovirus disease, both esophagitis and disseminated disease. That's also potentially devastating. The disseminated patients we've had have all ended up in intensive care because of it. We had another quite bizarre case of a man who'd lived his whole life in Ireland who got strongyloides, human roundworm hyperinfection syndrome. Strongyloides is not common in Ireland, at least we don't think so. But when you immunosuppress somebody who has strongyloides in their system, it has a tendency to disseminate the larva throughout the body and give you an immune reaction to it, which can also make you extremely unwell, more from your immune response to the worms than from them themselves. So that patient also ended up in intensive care because of that. And not to be forgotten, steroids can be horrendous on people's mental health. And we've had lots of people who've been admitted to psychiatric institutes because of depression, bipolar disorder, frank psychosis due to steroids. And they can't always be predicted. They're not necessarily the people who you would think were prone to this, who had pre-existing mental health conditions. It can be completely normal people who've lived their whole lives with no mental health issues, and steroids can trigger this. This is, might seem a derogatory term. It's not meant like that. It's meant, steroid cripple is meant to reflect the terrible state these patients get in, sometimes even when they're well managed. And they end up stuck in a vicious cycle of being on a moderately high dose of steroid and unable to get down on it because they get more pain and weakness when you cut it down, but then getting ongoing multiple side effects from the steroids themselves. And often when somebody ends up in that situation, it's either extremely difficult or impossible to fix it. So the solution, I think, has to be preventing it. Traditionally, we've done that with trying to be as judicious as we can in the use of steroids, but now we do have other ways of trying to limit steroid exposure. Before we get on to the steroid sparing or non-steroid treatments for giant cell arthritis, a little word on adjunctive treatments. So I have tended to give everyone aspirin. There's very little data to support giving aspirin to these people, but we give it because maybe it helps with preventing stroke or perhaps vision loss to some small extent, and it's generally relatively safe. Because of the steroids, I give them all a proton pump inhibitor, and I give them all some form of bone protection, going back to what I was talking about before, because everyone on this dose of steroids will get glucocorticoid-induced osteoporosis. They don't need a DEXA scan or anything else to decide whether they need to go on it. They just need to be on it. And once they're off the steroids, it can be reconsidered whether they need to stay on something or not. So lots of other medicines have been used for giant cell arthritis. Traditionally, these have all been tried to be repurposed from medicines we use in other conditions, and they haven't worked, generally. The one of the traditional agents that there was the best evidence for is methotrexate. It probably does help get the steroids down, but only by 1 to 2 milligrams a day. And that, for the vast majority of patients, is probably not worthwhile being on methotrexate for. Anti-TNF agents, which are revolutionary in most aspects of rheumatology, do not work in giant cell arthritis, and the infliximab trial was stopped early because it seems patients had a worse outcome when they were given it. So we don't use those anymore. Going back to the model I showed before, none of those agents target this model. And steroids don't specifically target it, but they are kind of a general, they suppress all lymphocyte responses, so they do have some effect in a general sense, but they're not targeted. But we do have agents that do target it. So we have agents that target T cells. We have an agent that targets interleukin 12 and interleukin 23 by a fortuitous accident. And we have an agent which targets interleukin 6, agent in rheumatoid arthritis. And it would be a logical thing based on that model to try in giant cell arthritis, and it has been tried. This is a phase 2 randomized controlled trial. This was a very strange study. It's small, as phase 2 trials tend to be. There's only 49 patients. But the FDA in America, for some reason, decided to mandate that everyone needed to get abatacept. Everyone needed an unproven treatment for this condition. So what they did, they gave everyone abatacept, and then they took it away from half the patients and kept giving it to the other half. And they looked at what happened over 12 months. And abatacept did seem to improve relapse-free survival at 48% versus 31%. So a small effect with a barely significant p-value. There was going to be a phase 3 trial of abatacept, which we were going to take part in, but the drug company who make abatacept have pulled that for commercial reasons. So it's not going to happen, and I don't think we're going to get much more data on abatacept in giant cell arthritis. But it does seem to work at least a little bit. This was a study I did. This is a common subunit they share. It was developed as an interleukin-12 blocker before interleukin-23 was known about, and fortuitously they blocked the right part of interleukin-12 that would take in the other cytokine as well. We think that most of its effects in psoriasis and psoriatic arthritis are due to its interleukin-23 blockade rather than its interleukin-12. But with both of them being important in the different pathways in giant cell arthritis, we felt it was worth looking at for GCA. So what we did, we gave it to our most difficult patients with giant cell arthritis, those who we had the most problems treating, who we just weren't able to get down off steroids. We've given it to 35 patients now. This is data from the first 25. And they, before going on ustekinumab, they were stuck at a median steroid dose of 15 milligrams a day. Weren't able to get any lower because they kept flaring every time they went below that. And that's a deeply unsatisfactory place to be. 50 milligrams is bad in terms of side effects. Patients get lots of side effects at that. But a year after giving them ustekinumab, they were able to get their dose of steroids down to 5 milligrams a day. This is a much better place to be. 5 milligrams is not that much more than our own bodies make. So it does have some side effects, but very minimal compared to the 15 milligram dose. We also found that it decreased the BVAS. This is a disease activity score. It's mainly used in GPA or Wegener's, but it's the only score that we had or have to use in giant cell arthritis, so we used it and it did reduce. And despite reducing the steroids, the inflammatory markers, ESR and CRP, also reduced with ustekinumab. So we have follow-up on those for over 2 years now on those patients. None of them who have stayed on ustekinumab have had a relapse of their disease while on it. 8 of the 25 of those were able to completely stop their steroids from being stuck on a median of 15 milligrams. Some of them were on other immunosuppressants like methotrexate. Most of those were able to stop them. And we also had some nice imaging data on them. So they have evidence of large vessel vasculitis on imaging before the ustekinumab. And it's either not gotten any worse or gotten better or completely melted away in all the people who've been given ustekinumab. And I think that's an important aspect because it's the one really truly objective disease measure we have for giant cell arthritis is the imaging findings we can see. You always worry with these biologic agents, especially giving them to elderly patients, if they're going to cause more problems than they help. We of course saw side effects. There was nothing particularly unexpected in this frail elderly population. Interestingly, 2 or 3 of our patients stopped ustekinumab due to side effects, and 2 of those subsequently had flares of polymyalgia 4 and 5 months after stopping the ustekinumab. So ustekinumab is given every 3 months. It's a very long half-life, so that we feel would be consistent with the ustekinumab wearing off and their disease breaking through. In contrast, none of the people on the ustekinumab who stayed on it had a flare like that. So that's ustekinumab, and that's the work I've done on it. That's not a randomized control trial, so it has to be interpreted with caution. There is more work going on ustekinumab at present in different places. Where all the attention and the money really has been is on tocilizumab. So tocilizumab is also used in rheumatoid arthritis. Again, it works just as well as any other biologic agent for that, but no better than any of the others. It's a monoclonal antibody against the interleukin-6 receptor. So again, interleukin-6 is theoretically on both sides of that pathway of giant cell arthritis pathogenesis. There have been 2 randomized controlled trials of tocilizumab in giant arthritis. This was the phase 2 study. This was done in Switzerland. They had 30 patients that they studied over a year, and they gave tocilizumab and prednisolone to one group and tocilizumab or prednisolone alone to the other group. Patients who got tocilizumab did much better. At week 12, 85% of them were in complete remission compared to 40% on steroid monotherapy. At week 52, 85% had relapse-free survival compared to 20% on steroid monotherapy. They got less steroids over time. They were able to taper the steroids better. And interestingly, they got less serious side effects. And that reflects what we feel in general practice. Of all the medicines we use for any condition in rheumatology, steroids are the worst. They have the most side effects of anything, the most infections, the most problems. And tocilizumab, while it does have some side effects, we would have expected it to be less than the steroids, but it's still nice to see that it actually was. So based on that phase 2 study, they went on and did a phase 3 trial. This is the JACTA study. This was published nearly 2 years ago now in the New England Journal of Medicine. This was also a slightly unusual study design. So they had 4 arms in this study. They had 2 different steroid monotherapy arms. They had one with a 52-week steroid taper, and they had one with an accelerated taper steroids to stop over 26 weeks. Neither of these are what we do generally in clinical practice. Our steroid taper ends up being longer than 52 weeks, but the 52-week is close to what we do. And the 26-week is obviously a very accelerated taper from this. Then they gave tocilizumab to 2 groups. Both of these groups were 26-week steroid taper, so an accelerated steroid taper. They either gave tocilizumab once a week or once every 2 weeks. And overall, they had 250 patients. This was a multi-center international study, recruiting patients from all over the world. About half of them had new onset giant cell arthritis and about half had relapsing disease. And their primary endpoint was at week 52. They also have an open label follow-up ongoing, but haven't published on that yet. So again, similar to the phase 2 study, there were very dramatic effects from tocilizumab. So essentially, with tocilizumab, compared to steroid monotherapy, 50% of patients were in sustained remission compared to about 15%. That number is much lower than the other study, which was up around 85%. The amount of patients in remission on steroids alone is also much, much lower than we'd see in routine practice. The reason for that is that they had a very, very stringent definition of sustained remission, including things like following the study protocol exactly and ticking all the boxes. So they've been very, very rigorous in how they assessed the effect of tocilizumab. But I think that the proportionate change between the 2 groups is still dramatic and pretty much better than any other treatment in any other area of rheumatology. This is looking at those 4 groups again, and what it's looking at is when they were flaring. And the blue box here is when the steroids were stopping in the 26-week groups. So it's showing a couple of things. It's showing the group on the 26-week steroid taper are flaring a lot when they stop steroids, which is perhaps not surprising. It's also showing that the 2 tocilizumab groups are essentially the same until you get into that blue box. And when you get into that blue box, the every week group seems to do better than the every second week group. So that's what's gone forward and been licensed as a dose. Not surprisingly, the tocilizumab again had a significant steroid sparing effect, about half of what the patients on steroid monotherapy got. The other interesting thing from this is that the 2 steroid groups, which are the 2 steroid monotherapy groups, which are these 2 lines, they eventually end up getting the same dose of steroids. And the reason that happened is because when they were more rapidly tapered off steroids, they had more flares and ended up back on the steroids. And so at the end of the year, got exactly the same amount. So the accelerated taper on its own doesn't seem to be the answer for giant cell arthritis. Again, we worry about safety in this group, in this group of patients. Tocilizumab, again, improved safety outcomes when it was added into steroids, which is reassuring. Despite that, there are still concerns about using tocilizumab. We don't really know how good it is at preventing ischemic events. There weren't enough patients in these studies having ischemic events in their follow-up because they were also on steroids to know. We don't know what happens after these studies finish, so we don't know if tocilizumab keeps working after a year. We don't know if you need to stay on it or if you can stop it, and will the giant cell arthritis stay in remission. So they're all things that need to be teased out. I said an advantage of what we had done is that we have objective imaging evidence. These, especially the second one, were very large, well-financed trials, yet they decided from the outset not to include imaging arms, and that worries me, why they decided that. There is still some concern over infection. In general, people were getting less infections with tocilizumab, but we all of us in rheumatology can think of particular patients who are on any particular biologic agent who had some horrendous infection which possibly ended up killing the patient, or at least making them very, very sick. So we always are a bit cautious about these agents, especially in people we feel are at high infection risk. The other thing I didn't really touch on, which is a potential downside to tocilizumab, is that because of the way it works, interleukin-6 is what causes CRP to be released from the liver. So if you block interleukin-6, you flatten the CRP, so it'll always be less than 1. And the problem with that is that it's quite hard to clinically assess if somebody with giant cell arthritis is flaring, or if they're just having a normal headache or a normal few aches and pains from the steroids or a viral infection. So we have relied a lot on CRP, and we won't be able to do that when patients are on tocilizumab. We've had patients who've gotten septic arthritis on tocilizumab and other very bad infections, and their CRP does not budge. It stays less than 1 despite this horrendous inflammatory process going on. So it's going to put more pressure on us and our clinical acumen in monitoring whether these patients are flaring or not. The other two blood tests we often use to measure disease activity, ESR and fibrinogen. Fibrinogen is also interleukin-6 dependent, so it's completely flattened with tocilizumab. ESR is less so, but it is reduced with tocilizumab, and it's also, we like it less as a disease activity measure because so many more things can affect it, and because it reflects more medium-term activity rather than the very short-term activity we'd like to be measuring. The last quote I put down the bottom here is from the GIACTA study published in the New England Journal of Medicine. It doesn't necessarily say there's anything wrong with the study per se, but I always put this up because it's my favorite line from any paper that's been published in the last couple of years. And this sentence is complete nonsense statistically. You cannot do this, but they did, and they wrote it down, and they still got published in what is supposedly the best medical journal in the world. So there's hope for us all, I think. So to finish up, I think it would be unfair not to tell you what I do in giant cell arthritis. There is some controversy in this, and different experts will do different things, very different things in some cases, but this is what I do. So in general, most people who come in with giant cell arthritis, I still give them steroid monotherapy. I don't give them all Roac/Timra or tocilizumab to start off with. I do give some people tocilizumab at the start if I think they are at high risk of steroid adverse events. So if they've already got osteoporosis and diabetes and hypertension, I will often give it to them at the start. If I think they're at high risk of running into trouble with their disease, And that's a bit of a nebulous concept. There's no one thing I can say predicts that, but sometimes people come into me and I just get a gut feeling that they're going to get into trouble. I might consider, after discussing it with them, suggest that they take tocilizumab at the start. If someone flares, especially if they have a couple of flares, I will add in tocilizumab. I haven't yet seen anybody who's relapsed on tocilizumab or had a reaction to it and had to come off in the joint arthritis population. We have options there. Because I'm familiar with it, I will tend to use ustekinumab as my next agent. Most people, I think, would probably use abatacept because there is some randomized control trial evidence for it. It's randomized evidence that's saying it's not great, but at least it's positive evidence. And I said people will do different things. So some people out there are giving tocilizumab to everyone, all comers with joint arthritis. Some people aren't using tocilizumab at all in joint arthritis. And it depends on your country as well. In the UK, they are limited. They can only use it for relapsing disease, and they can only use it for a year, so they have to stop it after a year. If I was working in the UK, I would be quite reluctant to use tocilizumab at all because I don't want to be stopping it after a year. I'd be very worried that I'd have no appreciation of that person's disease and how much steroids they needed. But thankfully we don't have such restrictions, at least at present, in Ireland. So that's everything I have to say. I'd be happy to answer any questions.
And thanks, Dr. Comey, for a really interesting talk. A lot of new information there as well. I was just wondering about in the initial presentation of giant cell arteritis, two things really. Are there any specific features of the headaches other than, say, the visual loss or other things? And the second thing is, in terms of maybe us doing inflammatory markers, I know if we were really suspicious or there was visual loss, we're just going to send them straight in. But you mentioned inflammatory markers in terms of kind of known disease monitoring. ESR versus CRP, obviously we do both, but are either of them more predictive?
So the first question, there's nothing you can trust in the features of the headache. There are certain things that make it more likely. Okay. So if somebody who's never had headaches in their life and now they're 70 and they're suddenly had a headache that's lasted for weeks, that would be suspicious. If somebody has gotten a much worse or a very different headache to their normal headaches, that would also be suspicious, either for joint arthritis or something else not good going on. Some people will localize their headache very specifically over the temporal artery and say, they point to it and say, I'm sore there. That's unusual, but if it happens, it probably shouldn't be ignored.
Yeah.
Those patients are great who give you very particular histories that really make you think about it, but there are lots and lots of patients who come in with very vague, generalized headaches who end up having joint arthritis. So it is difficult to catch them all on any one feature. Inflammatory markers, they're definitely worth doing. I do ESR, CRP and fibrinogen in all of them, and for an individual patient, one of them might be better than others, and I would use that one then to monitor their disease activity.
So fibrinogen is the last one, is it?
Fibrinogen, yeah. And that goes on a coagulation sample, and so it might be hard to do outside of the hospital setting. It's hard to do even in the hospital because the lab don't realise it goes in a coagulation bottle, so they often won't take it for us, but we can get it done. Of them all, CRP is the best. For the average patient, it's most likely to give you the most information. Patients with giant arthritis can have completely normal inflammatory markers, all of them. So I don't think the decision to refer them on should necessarily be based on the inflammatory markers. If the suspicion is there, they have to be treated as giant arthritis. People who have lower or normal inflammatory markers are actually more likely to get ischemic events. They're more likely to get vision loss or stroke. And that's kind of a paradoxical immune response to it. But to some extent, they're the people we should be most worried about.
Okay, thanks for that.
So I think if in doubt, on steroids and onwards. Yeah.
Sounds good. Any questions for Dr. Conway? Back there.
If I may ask two questions. Yes, the first one was on gout. Would you care to say anything more about the other auto-inflammatory diseases? And the second question is giant cell arthritis really an infectious disease? There have been certainly plenty of reports of varicella and propionibacteria. I mean, should we be treating these people with antivirals in particular? Because that seems to be the most common, or possibly antibiotics.
So I'll answer the second one first. Giant cell arthritis, there have been lots and lots of studies identifying different agents in the arterial wall or different associations with different infections, varicella being the most common one, but lots and lots of other ones. When those studies, when people have tried to replicate them, they've never been able to consistently do that. Most recently, there was a group in Colorado showed in lots of studies in different ways the presence of varicella in our temporal arteries, and other groups couldn't replicate it. So eventually, to try and confirm it or not, a group in Italy got the reagents and the equipment from Colorado, the exact same, and tried to replicate it and still couldn't find it. So my feeling about, there's a couple of things going on to explain why people are picking up these infections. One of them is that they're actually there, but they're not causing the giant cell arthritis. Whenever you get a large number of immune cells in one place, you tend to find accumulations of viral particles and other DNA, RNA in that area. But that doesn't necessarily mean they're reflective of what is actually going on. But I also think a lot of it is technical issues and contamination of samples. Interestingly, when Horton first described giant cell arthritis, he reported it in his first paper as a fungal infection because he found fungi in the initial temporal arteries, and eventually they figured out what was happening was the laboratory in the Mayo Clinic was completely contaminated with this fungus and it was getting into the samples. So they were initially treating people with antifungal agents for this, and sometimes it was working and sometimes it wasn't, but it was probably working because the disease was naturally going into remission. But I don't treat people with antivirals or acyclovir or anything like that. I don't think there is enough evidence that we should do that. We don't know what triggers the dendritic cells to set off giant cell arthritis, and it is entirely possible it is something like varicella, but I think that once the triggering is done, the infection is gone and the process is just self-perpetuating. So I wouldn't advocate treating them with antivirals. The other question about other autoinflammatory syndromes, do you mean ones like gout, so like calcium pyrophosphate and like familial?
I think in the name of time we might check if are there any other questions? Are there any questions from our webinar audience? Okay, well, thank you very much to both our speakers for two really interesting talks. Thanks very much to Blackrock Clinic for hosting this evening. And yeah, so and thanks to everyone for coming. Thank you.